Thank you very much. Thank you, and it's my honor to be here. I see a lot of new faces, but also a lot of familiar faces. So I know I have been here for a little while. I came here to this area in 1991, and I do have 2 boys, and I wondered how you knew so much about me, and then I realized you looked on the web, and there's that little, I go, oh yeah, that's it. But so I am pleased to be here. Urology, certainly there's some topics that are, I guess, less maybe private, but my passion have been 2 particular areas that, you guys probably know now that I'm going to talk about: male erectile dysfunction and urinary incontinence. And so those are, it's interesting, the evolution of how information has gotten out to folks. And I think I was sitting here at the table talking, and we just had a frank conversation and about some of the issues that men and women face. And it's just interesting to see how people have been more and more willing to talk openly about these kind of issues. And I think that's very important, and it's great, and it makes my job a lot easier when people come informed and don't feel like these topics are off limits and they're something that they're wanting to discuss. And just to briefly give you my background, it's on here. I wanted to see what was being said about me, but I did go to medical school at Duke University, and my residency was at, I did 2 years of general surgery at Baylor and 4 years of urology. And it's interesting because I actually was at Baylor when Brantley Scott was there, and he was the first person to begin putting in inflatable penile implants. And so I had an initial introduction to that surgery from the gentleman that, I won't say he invented it, but he was certainly critical in the moving forward from the laboratory and engineering aspect to the patient care realm. And it's always been an interest of mine to address male erectile dysfunction, as it is part of urology in general. And as we have diagnosed more and more prostate cancer and had treatments for this, and people are living longer, erectile dysfunction has become a bigger and bigger issue. And just to kind of, and what I'm going to do also is I'm going to go through things relatively briefly, because we're covering 2 really big topics, and I do want to give everyone a chance to kind of feel like they got what they came here for. And so I'm going to move through the erectile dysfunction talk, and then what I want to do is take some questions, and then we'll go to the incontinence. And with the incontinence, I'm mainly going to focus on female incontinence, although male incontinence is certainly an issue as well. But erectile dysfunction, to get back to that, if you kind of look at how things have gone, one of the biggest things that happened was the PD5 inhibitors, which are Viagra, Levitra, Cialis, the medications that were available to treat ED. And those medicines ended up with commercials, and those commercials generated a dialogue, and I think that helped move us forward in being able to discuss these things. It's interesting, that medication was in a study, and it was being looked at as a heart medication, but the men that were taking this medicine, it wasn't great when they measured parameters for the heart medication, but they wouldn't give the medicine back. And so they started going, what's going on here? And the more they kind of asked questions about it, the more they realized, hey, we're on to something here. And so that's kind of how Viagra was the first one, and then I believe it was Levitra and Cialis, and they all work basically very similarly. And a lot of times that's the initial treatment that men undergo for erectile dysfunction. If that medication doesn't work, then usually the second line therapy is, in some cases, the vacuum device, which some of you may be familiar with. It you slide the vacuum device over the penis and you actually create a vacuum that pulls blood into the penis, and you put a ring at the base to hold the erection. The advantage of the medication obviously is that that's probably the simplest, and there's less maneuvering and that kind of thing to use it. The vacuum device obviously doesn't involve a surgery, doesn't involve side effects of medication potentially, and it's relatively inexpensive, but the penis tends to be relatively cool, or I won't say cold to the touch, but cool. And so some people find that to be not very satisfactory. And then also it can sometimes be hard to seat the ring at the bottom where the abdomen and the penis meet. So that's kind of second line therapy along with injection therapy. Injections, you actually give the medication into the penis with a very small needle. And usually within about 10 minutes or so, you're able to have an erection. It does require adjusting the dose. It requires, in most cases, refrigeration, or at least not allowing it to get much beyond 70 degrees, but it generally lasts better refrigerated. There can be some pain with the injection. It can create some scarring, but that is, for a lot of men, more physiologic than the vacuum device. So obviously, of the ones we've gone through, the medication that you take, a pill, is by far the simplest. The vacuum device is more mechanical. The injection requires that you store the medicine and can be relatively expensive. And someone was asking me, well, has there been anything new or improved in the treatment of erectile dysfunction? And I think that the biggest improvement from the time when I trained with Brantley Scott to now has been all the changes in the penile implant and the surgery. And you know, it used to take longer to do, sometimes would involve multiple incisions, and now in general, I can do an implant in an hour and a half or less. Patient stays overnight, and the device can be used about 6 weeks after the procedure. Over 90% of patients are pleased that they went through the surgery. I think the exact number is like 94%, and 92% of their partners are glad they did it. So it is definitely a couples phenomenon, and I had a patient and his wife that were going to talk about their experience, but I will kind of take over. He had a funeral he had to go to, so he couldn't make it. But what he often talks about, and it made a big impact on me, and his wife talks about it as well, her experience with this and how he went through prostate cancer surgery, and one of the side effects was the loss of ability to have erections. And along that process, they had some emotional issues, not major by any means, but just the intimacy was lost. And what he said, and it really has made a big impact on me, and it's why I'm passionate about helping people work through this problem, is talked about a husband and a wife, and that you really don't have this relationship where it's a close emotional bond and a close physical bond that you have with no other person on the earth, for the most part, and just how important that connection is with another person. And just when he talked about that, it made me realize just how important it is to be able to openly talk about erectile dysfunction and help people work through these issues and try to choose what's right for them, whether it's everything from nothing to all the way to deciding on implant surgery. And more and more people are choosing to go ahead with implant surgery. So I think I'll open it up for some questions now, and we'll try to answer a few questions, and then I'll talk about incontinence next. Does anybody have any questions at all? Yes, ma'am. Oh, I thought you were thought somebody was making a motion back there. Well, I know it's hard to talk about these things maybe at a lunchroom conversation, and it's pretty intimidating. I do speak a lot at seminars, and we you know, a lot of times people come in knowing that they want to discuss this, and so it's not unusual for people to have questions about this. And if you don't feel comfortable asking it in this large group, I am more than happy to talk with anyone after and try to give you more information. And also there's some brochures on treatment of erectile dysfunction. If you care to avail yourselves of that, there should be hopefully enough brochures for everyone that's interested to have one. Yes, ma'am.
Since you've been in practice, do you see an increase in the number? I know something, you know, the people are more open, so it's not always been with us, has it? Erectile, or to the amount it is now?
Well, I think both people talk more openly about it, and I think the other aspect of it is that as there's been more treatments for prostate cancer and people are living longer, I do think there has been some increase in the incidence of erectile dysfunction, but I think it's just also people are willing to talk about it as a part of their life that they want to continue as they get older. And I think that's true of a lot of us now. We're not willing to just accept where we are. I mean, you know, I know a lot of you came from an exercise program. You're trying to keep yourself going, and I think society is much more open to the idea of seniors as maintaining their sexuality, maintaining their health and fitness, and being an integral part of society, and not just you know, off to the side as it has been sometimes in the maybe in the distant past. Yes, ma'am. Erectile dysfunction? Well, there's three main causes of it. The first and probably the most common is in somebody who hadn't had surgery is arterial inflow disorder or hardening of the arteries. It's interesting that men who have erectile dysfunction at a very young age, and when we say very young age, under the age of 50, their incidence of heart disease going forward and the potential for heart attacks is substantially higher. So it's kind of the canary in the coal mine indicating that you could have a vascular problem if you're having major problems with erections under the age of 50. The other thing that is a major factor in erectile dysfunction is nerves. During prostate cancer surgery, the nerves run very close to the prostate that control erections, and those nerves sometimes are temporarily damaged and sometimes permanently damaged. Not to say that it's unique to the surgery, radiation also can affect those nerves and cause scarring, and there's another treatment that I do for prostate cancer which is called cryotherapy or freezing, and that can affect the nerves. So most of the treatments that involve prostate cancer are potentially an issue with a neurologic related form of erectile dysfunction. There's a third one that's a little bit harder to quantify sometimes, and that's venous leak, where the arteries flow in appropriately but the veins drain too quickly. And so those are the main physiologic causes of erectile dysfunction. And it's not super important to figure out which one it is. I know it seems like it would be, because the treatments are the same, and you can spend a lot of money trying to figure out which one of these it is, and you still end up working through the algorithm the same way. So, yes, sir. I'm sorry, I heard that. That's a great question. I think poorly controlled diabetes definitely accelerates erectile dysfunction, because the main thing that diabetes seems to affect as far as erections is microvascular. It's the same reason why some people get some renal disorders. With diabetes, you can have some nerve issues as well, but we think most of it is microvascular. So in the microvascular system of the penis, that you start having trouble with erections. And poorly controlled diabetes definitely accelerates it. But for reasons that we don't completely understand, even if you get your hemoglobin A1C, which is kind of a measure of long-term control of diabetes, even if you get it under what appears to be perfect control, there is still some acceleration of erectile dysfunction among diabetics. And it's interesting that diabetics tend to have the erectile problem earlier, and it becomes resistant to medication and shots. And so many more diabetics move on to select a penile implant because they tend to be presenting with the disorder at a point where they're not willing to give up erectile function, and none of the other options work very well. Yes, sir. Absolutely. Smoking affects your heart, smoking affects erections, no question about it. High cholesterol also can affect erections. Anything that affects the vascular system, if you think of things that are concerning for heart attack, they're also concerning for erections. And erectile function is a very good measure in a lot of cases, especially, as I said, in earlier onset ED, of the situation that's going on with your coronary arteries, much more predictive in younger folks than older folks that the erectile dysfunction can be associated with later cardiac issues.
I don't hardly know how to ask this. The penile implant, now, in the process of getting that done and afterward, is there a lot of pain that goes with that?
That's extremely variable. And it all boils down to, it's a three-piece implant. There's cylinders that are placed, there's a reservoir placed, and there's a pump mechanism. And all this is in some of those brochures over there for those of you that are interested. But the biggest issue that I find that determines how much pain you have is in the placement of the scrotal pump, how much swelling you get with that. And I put in 2 implants last week. One guy had pretty significant scrotal swelling, fairly uncomfortable. The other guy had virtually none, which is what I see most of the time. And he had very little discomfort. And so it all comes down to the placement of the scrotal pump. And I wish I could tell you why some people get scrotal swelling versus others. And it's certainly something that I'm focusing on in the surgery to try to see if I can figure out if there's a way to control that. But overall, I would say that most people, you know, you stay overnight in the hospital and you go home and you're uncomfortable, but you're not like debilitated. And it is 6 weeks before you can use the implant, but it's about 2 weeks or so of some, what I would call tolerable discomfort. Well, I'm going to move on to talk about incontinence, and I'm going to, in fairness to women, although having said that, I think it's interesting that more and more women are also engaged in this conversation on erectile dysfunction, but and certainly male incontinence is a big issue, especially again after prostate cancer surgery. But if you look at the sheer numbers of people that have incontinence, it is mainly or there's much larger numbers of women that have issues with urine control. And urine control is a fairly complex problem. And when we talk about urinary leakage, I know to most of you, leakage is leakage. I mean, it's, am I wearing 1 pad, 2 pads, 3 pads, 5 pads? It's just, I'm leaking. But to me, there's a very big difference in the type of leakage that you have. And there's 3 main kinds of urine leakage. And there's urge incontinence, which is kind of where you're going for the key, you're trying to get in your house, and between that key going in the door and getting to the bathroom, you're in trouble. And it's what I say, your early warning signal is broken and you're having trouble getting there. That type of leakage, there's probably, I think, at least 7 different overactive bladder medicines, and you've probably seen some of the commercials on TV. And that is mainly designed to try to lessen the sensation of the need to urinate. They're called overactive bladder medications. They work to varying degrees. The most severe overactive bladder issues generally are in somebody who may have had a stroke or has Parkinson's or some other neurologic disorder, multiple sclerosis. There can be some really significant urgency issues, and the worst urgency issues that I've seen are usually in patients who've had a stroke or some type of brain injury. But it certainly doesn't require that for you to have a problem. Doesn't mean you've had a brain injury. There's lots of women who the key in the door, their early warning signal is broken and it's just hard to get there. And I'm sure to varying degrees, you either have that problem or you know somebody that has that problem. So the medications are one treatment for that. If the medications don't work, then there's some exciting new treatments available. One is Botox, and that's not in your face, it's in the bladder. And what that does is it relaxes enough areas of the bladder to allow you to hold urine better. And it works really well for a lot of people who have failed the medicine, kind of like erectile dysfunction. The first thing is a pill. And really in overactive bladder, maybe the first thing really should be diet. Controlling caffeine intake and acidic foods and that kind of thing. And we go over some of those dietary issues. So diet and pills, and then if that doesn't work, Botox is a second line treatment, as is an electrical stimulator called the InterStim, which is put in right at the sacral nerve that controls bladder function, and it's had some really dramatic results in people who failed other options. Another possibility is biofeedback, where you learn how to control your bladder, because it's kind of a subconscious thing, and some people get into these patterns that they need help to work through with biofeedback. And at Greenville Memorial, we're developing a pelvic floor center to specifically address some of those issues and help people with biofeedback and physical therapy. Another major type of urine leakage for women and men actually who've had prostate cancer surgery, but women is probably the largest group that has what we call stress incontinence. And that doesn't mean that you're anxious or upset about your life. It is leakage when you sneeze, cough, laugh, exercise. And so anything that involves increased abdominal pressure. And it's really important to me when I ask questions to try to get beyond how many pads you're leaking and try to figure out when you're leaking. And with stress incontinence, Kegel exercises, which I'm sure you've all heard of, help some, but in many cases it requires surgery. So overactive bladder, there are surgery kind of, I mean the electrical stimulator or Botox injections, but I generally consider urge incontinence to be mainly a non-surgical problem, whereas stress incontinence, generally there's a lot of folks who need surgery. And I'm sure you've seen on TV the 1-800 bad mesh and people talking about the synthetic materials that have been used. Unfortunately, the urinary or the vaginal sling, which is putting a very small piece of mesh underneath the urethra, has been lumped in with some much larger, bigger operations that involve a lot more mesh. And it's kind of like, taking one pill versus the whole bottle. And so, not to say that those larger meshes are always bad, but those are where all the major problems were. And the FDA has come out with a position paper that has said that, that the vaginal sling is still a very appropriate treatment option, and their level of concern over the use of it is way different than pelvic suspension and some of the bigger meshes. And it gets very confusing for patients when they hear these things on TV, and then the first thing they see the urologist and you start talking about a mesh sling. It's kind of worn down a little bit where people aren't immediately as concerned about it, but it actually in some ways has been a good thing because it has stimulated me to talk a lot more about why you want to do this and how you want to do this, and I think patients go into these operations now much more informed. But the surgery itself only takes about 20 minutes, and it can be a life-changing thing, from leakage when you sneeze, cough, laugh, and not able to exercise, to being, if not completely dry, much drier. So there's urge incontinence, stress incontinence, and then there's a third one called overflow incontinence, which means your bladder muscle doesn't work well, you retain urine, and the main reason to know about that is if it's really severe, unfortunately, well, the electrical stimulator works some, but for a lot of folks, you just have to do in and out cath to empty your bladder. Fortunately, most people don't get to that level of trouble. But what I like to do is look at some tests to make sure that you don't even have any of that problem, because you don't want to put a sling in somebody who's already borderline retaining urine, because then it will throw them over into likely not being able to urinate and then require that the procedure be undone. So there's tests that I do to try to figure out, in addition to the history, which type of leakage you have, so we can try to direct your therapy based on the type of leakage. And males also have some of the same issues, and I've left a couple of brochures, and the male incontinence issues involve, in some cases, a sling very similar to women, but also in more severe cases, an artificial urinary sphincter, which has some of the similar mechanics of a penile implant, except a much smaller pump in the scrotum, and you're pumping fluid out of the cuff that's pinching off the urethra instead of pumping fluid in to an implant, as with erectile dysfunction. So there's the female incontinence brochure, there's a male incontinence brochure, there's an erectile dysfunction brochure back there with also a little DVD. I don't know if any of us still have DVD players, but it's certainly available. And does anybody have any questions about urinary incontinence?